Well, hello everyone, and welcome back to Human Biology here at Chaminade University. Today we're going to delve into the cardiovascular system, which is Module 8A in your syllabus. So the point of the cardiovascular system is to transport your oxygen to your cells, to transport the carbon dioxide away from the cells, to bring in the groceries, i.e. the nutrients, and to take out the trash or the metabolic wastes. It also serves to circulate other biomolecules like hormones, etc., that are going to be circulating throughout the bloodstream to be able to ensure global delivery to all of the cells. It's also going to serve as a function in regulation of things like our body temperature, which we do by vasoconstriction and vasodilation. And these terms basically mean constriction of the blood vessels, vasculature constriction, or dilation of the blood vessels, which can increase or decrease the amount of blood that is found in that region. And if we can send more or less blood to the surface of the skin, we can regulate our our blood temperature. But we can also regulate our blood pressure via that vasoconstriction and vasodilation. If you picture that you tighten down on a hose, the fluid inside it is going to be traveling at a higher velocity. And last but not least, the cardiovascular system serves to play a role in the protection of our body via the clotting response if we injure our blood or blood vessels, either internally or externally, as well as by the circulation of immune cells, which are going to help attack any foreign invaders like microbes, fungi, viruses that are trying to invade and take over our systems. All right, so the heart is this very strong muscle. It's the biggest pump in the body, if you will. It has specialty types of muscle called cardiac muscle tissue. Now, cardiac muscle tissue has to work in concert, so it means all of the cells have to beat with specific regularity and rhythm. And that means that they have to be able to communicate with each other. So we have these specialty regions called intercalated discs. Which are going to have these little regions here with gap junctions that allow them to have tight connections, or not to allow them to have tight regulation of when they contract, as well as connected via desmosomes here, which are like little snaps that basically hold the cells together. These cells are multinucleated. That means they have more than one nuclei. They're going to be striated, so you see these little lines there. And they're going to, again, work in concert. They have many mitochondria and, again, multinuclei because they're going to have to do a repetitive function over and over, and they're going to need a lot of coordination to do this, as well as a lot of energy, which, again, is going to be coming from the mitochondria. Okay, so cardiac muscle tissue have at least one, but typically multiple nuclei that are typically located right in the center of the cells. Again, they're striated tissue, and they use a mechanism called the sliding filament mechanism, which we'll discuss in a little bit, for contraction. And they have specialty branching regions, and they have a region, again, called the intercalated disc. The intercalated disc is held together by desmosomes, but also has gap junctions that allow for communications. So these junctions are really critical because it allows what we call electronic coupling. That means the cells that are adjacent to each other are going to fire at the exact same time. Additionally, we have a ton of mitochondria. They're going to make a lot of energy. We use that energy to continue to keep the heart pumping so that we can prevent what we call fatigue. And we also have autorhythmicity. We have two separate sets of nodes within the heart that are going to stimulate the action potential. One stimulates the lub, the other stimulates the dub of the heartbeat. And again, this is called autorhythmic. And we have a specialty time frame called the refractory period. It's an absolute refractory period. That means that we cannot initiate a secondary impulse so that we don't end up with tectonic contractions. So essentially what we want to make sure is that we have a lull before the next beat. That's an absolute refractory period so that we don't end up with a inability of the heart to pump. We want it to actually stay in this nice rhythm. Now, we do have a small percentage of the cardiac cells that are not involved in contraction. They're involved in the conducting system, and they're going to be basically the electrical cells. Again, they talk via these gap junctions. And this conducting system is what's going to initiate the lub and the dub. So it's going to keep the heartbeat on rhythm, and it's going to also spread that impulse very quickly throughout the rest of the cells. We also have a specialty peptide called atrial natriuretic peptide, or ANP, and ANP is involved in the regulation of the concentration of sodium in both your blood supply as well as in your extracellular fluid. And if you know anything about the way that water works, water is going to follow the sodium. So if we have a high concentration of sodium, we're going to have the water following into that cell, and vice versa. And so we're going to use this to regulate our fluid balance, and it's going to work in the opposite direction of aldosterone, which is going to be a water-conserving peptide. All right, so this is the anatomy of the heart. The heart is located within the lungs in this region here with the cardiac notch. It's going to be surrounded by what's called the pericardium. You can see that here, just like the lungs are surrounded by that pleural sac. The heart is surrounded by the pericardial sac. That's going to allow, it's basically like a membrane cavity that has liquid inside, and that's going to allow it to pump without being subjected to the forces of something like friction, repeated over and over stress. Okay, so the heart is going to have multiple different morphological conditions I want to talk about. So we're going to have blood coming in through venous return. Now it can come in through multiple locations. It's going to come in through the inferior and superior vena cava, as well as the coronary sinus, which is where the blood flow from the heart itself is going to be feeding in. So the heart itself is serviced directly off of the aorta. Blood supply goes right around and then dumps right back in. So that's going to be some of the high intensity. I'm going to use a lot of oxygen. And so once it comes back off of the cardiac route, it's going to dump right back in to the right atria, which is where the blood's going to come in. So again, blood comes in through the right atria, then it's going to go to the right ventricle, then it's going to be expelled out of the heart into the lungs, out through these pulmonary arteries. When it goes out from the pulmonary arteries, it's going to go to the lungs, then it's going to return back in through the pulmonary veins, and then, so here, pulmonary veins, and then it's going to go into the left atria, left ventricle, and then it's going to be expelled out through the aorta to feed the rest of the body. We have three main branches that come off the aortic arch that are going to feed three major regions of the body. We also have the descending aorta, so it's going to go up and then head straight down, and that's going to feed the lower, the middle of the body, like the thoracic cage, etc., as well as the lower limbs. All right, if we take a cross-section of the heart and we start looking at the chambers, first I want to start looking at the actual wall itself. So the wall of the heart is comprised of three main layers of muscle tissue. So we have the myocardium, which is this main layer, the middle layer of the muscle tissue. And we have the endocardium on the inside and the epicardium on the outside, which is really the visceral pericardial layer. So remember, this is the pericardium, and it's going to be a sac that has fluid. So we have the visceral layer, which is lining the heart, and the parietal layer, which is going to be closer to the outside. And so the epicardium is actually the visceral pericardial layer right here. Okay, one thing you'll notice very quickly is that this left side is a lot larger muscle-wise than the right side. And why is that? Because when blood comes in to the heart, it's coming in through seepage, basically. It's sucking itself in. It's not under pressure. It's actually really the opposite. It's under negative pressure. If anything, it's going to be pulled in from the contractions of the heart. And so it's returned by the skeletal muscle pumps and other things as well, but really it's just going to be returned by basic one-way valves and seepage. So it seeps in here to the right atria. Then it goes through this here is, it's going to go through this valve here, the atrioventricular valve. The right atrioventricular valve is then going to go into the right ventricle, shown here. And then we're going to expel it out through the semilunar valve into the left and right pulmonary arteries, which will feed the left and right lobes of the lungs. Then we're going to bring it back in through the left and right pulmonary veins into the left atria. It's going to go through the left atrioventricular valve. And then it's going to go into the left ventricle. Here it's under a lot of pressure. Okay, now it's returning back under pressure. So it's going to be expelled out, again, also under high pressure through this aortic semilunar valve, which is going to take us out to the aorta. Again, three major branches off of the aorta, and then the descending aorta is going to head down to feed into the abdominal cavities and feed all of the abdominal organs. Okay, some other things I want to point out here. Here's the fossa ovalis. This used to be a little hole, going to be a little hole that connects the two chambers of the atria, and that happens early on in development because as the heart is being created, it can't quite handle the pressure as it's going to be under structural. So we have a little bit of overflow where the left atria ends up under too much pressure. It can just push it back in through the fossa ovalis into the right atria. That's obviously going to be sealed off in the adults. Some other things here of interest, here's some chorda tendente. These are going to be responsible for holding this semilunar, this is the atrioventricular valve, but it's going to be holding this one-way valve closed. And we also have the papillary muscles that are going to be helpful with that as well. So, and then this region here, which is in between the two ventricles, that is known as the intraventricular septum. So septum just means separation between the two ventricles, so intraventricular septum. Okay, so now we're going to do a cross-section where we're actually looking downward into the valves of the heart. Here we're going to note that the valves are going to be inverted from each other. So the aortic valve and the semilunar valve work together. They're both going the same direction, i.e. out from the heart. And this left and right atrioventricular valves, these guys are going to be going the same direction as well, i.e. into the heart from the atria into the ventricle. So these two here, if you could picture directionality, they're coming out of your screen towards you. And these two here are going out of your screen behind the screen. Okay, and they're going to work in a concerted fashion. So these two work together, and then those two work together, right? These two are the lub, those two are the dub. Lub, dub, lub, dub. So this is the circuit of blood flow throughout the body. We're basically I'm gonna start with the blood coming in. So the blood's gonna come in through the right atria. That's here. Then it goes to the right atrioventricular valve. That's here. Then it goes out into the right ventricle and then out through the pulmonary valve here into the lungs. It's going to take us through, these are the pulmonary arteries. It's the only time you're going to see arterial flow depicted as blue because it's not yet oxygenated. And then we're going to see the veins returning, these pulmonary veins, returning with oxygenated blood into, so here's the capillaries of the lungs where we're going to end up getting that oxygenation. Now we've got the pulmonary veins returning with oxygenated blood. Here's our left atrium. We're going to go through that left atrioventricular valve into the left ventricle. Then we're going to have a deep contraction from that left ventricle out through the aortic valve, which is going to take us out through the aorta. Now that was all going to be cardiac. So here we have cardiac circulation, then we have pulmonary circulation, and then we have cardiac circulation. Okay, that's all what's considered to be cardiopulmonary circulation. But then once we leave the heart, then we're going to head out through the body, and this is called systemic circulation. Here we're going to flow out from the aorta, which is the largest arterial vessel, largest elastic artery. Then we're going to feed into arteries. Arteries feed into capillaries. We're going to have a lot of fluid loss and gas exchange. Then venules are going to be where we're starting to drain this fluid back. And then the venules lead into veins, and the veins lead into the vena cava, which is going to lead back into the right ventricle. So that's the flow of blood throughout the heart. Now, the cardiac cycle refers to the multiple events that have to happen in concert in terms of the blood flow and the volume in the different ventricles and the pressure in the different regions and maybe the sounds that are made that are all happening during one heartbeat. Now, heartbeats are going to have a contractile phase and a relaxation phase. So we have the contraction phase, which is called systole, and diastole is going to be the relaxation phase. And basically, when you're measuring your blood pressure, you're measuring the highest pressure, which is happening during the contraction, over the relaxation. So systole over just diastole, right? And we're looking over here. This is an overview of the cardiac cycle. If we're looking at the left ventricular pressure, or LVP, you'll note that we're going to end up with a contraction that's going to cause an increase, a giant increase in that left ventricular pressure. So that first lub, when we're going to be squeezing on the atria, that's going to push all of the liquid out of the atria into the ventricles. Then at the height of the ventricular pressure, then we're going to have that second contraction, which is going to push all of the liquid out of the ventricles into the aorta or into the pulmonary circulation. Okay, so the left ventricular pressure is going to see a little bit of a spike with the first contraction and then a very large spike during the dub, right? And then here we have the left the end diastolic volume and the systolic volume. So you can see that the volume in the heart is going to increase until we do that second squeeze. When we do that squeeze, we're actually pushing all of the volume out of the heart. So the volume, the diastolic volume is higher than the systolic volume because the systolic volume is when we're contracting and pushing everything out. So when the heart is contracted, there's less volume inside it to begin with, which pushes, again, all of the blood out. And then the blood's going to start to refill very slowly until we get back to the diastolic volume. Okay, this is the actual ECG, which shows the different contractile events in the different regions of like the heart. So we're going to have a contractile event that's going to happen in the atria, and then a contractile event in the ventricle. So that's kind of what we're seeing as the electrical excitability of these different phases here. And then the sounds, this is the lub, and that is the dub. So this is an overview of all of the different things that are going to happen throughout the cardiac cycle. All right, so what is the point of pumping the blood around, right? The point of pumping the blood around is to feed the cells of the body. Okay, great. So who feeds the cells of the heart? Good question. So there's a particular siphon that comes right off of the aorta and feeds the heart itself. So the blood that's being pumped through the heart is not actually exchanging nutrients and metabolic waste with the myocardial cells. It's just being pumped through. The blood supply that's going to feed the heart is going to be fed through these coronary arteries. Again, it's going to come right off of the aorta, going to feed these coronary arteries, and it's going to return from the coronary veins right back into the coronary sinus directly into the heart. Right? So the coronary arteries are going to exit out from behind the aortic cusp right here, from the very first part of the aorta, and then we lead into a branching network of different arteries, arterioles, capillaries, venules, etc., similar to other organ systems, and we're going to end up draining back in to the coronary sinus, which is going to empty right in to the right atria. So everything's going to drain back into the major coronary veins, then into the coronary sinus, which empties into the right atria. All right. As I mentioned, the coolest part about the heart is that it is electrically excitable, and it electrically excites in concert. That means that all of the cells that are going to get that excitation signal are going to get it at the same time, and they're all going to contract in unison. So the heart is innervated by a lot of different sets of nerve tissue, but an overview of the nervous system, which we went over previously, is that we're going to split the nervous system into sympathetic and parasympathetic sections. So sympathetic is your fight or flight. Parasympathetic is your rest and digest. So the sympathetic nervous system is going to innervate the entire heart and node cells and releases what's called norepinephrine, which is like an adrenaline molecule. And the parasympathetic system is going to innervate the node cells, but not the entire heart muscle, and releases acetylcholine. So my point is that the sympathetic nervous system is going to increase the rate of the hearts by working on the heart muscles and increasing norepinephrine release. Whereas the fight or flight response is going to slow down your heart rate by releasing acetylcholine at the nerves, at the node cells. Okay, so this is talking about electrical conduction here. We have two major nodes. We have the sinoatrial node and the atrioventricular node. They're going to contract at opposite times. So SA is the lub and atrioventricular is the dub. So what happens here? So these are electrically excitable. And what does that mean? That means that we can change the concentration of positive and negative charges on either side of the membrane and induce an electrical signal when we get a gradient difference. So we start off with a negative 60 membrane potential. That means that we're going to have more negative ions than positive ions. And then we're going to end up with a reduction in permeability of potassium. So we have less positive ions moving out because the membrane potential is negative, right? Then we're going to have a specialty type of sodium channels that are gated by electrical charges. So when the electricity reaches a certain threshold, basically when it hits this negative 40, these voltage-gated channels are going to open. When they open, sodium is going to move into the cell, leading to this rapid depolarization. So we have a nice slow increase in positivity until we get a rapid depolarization. We actually end up flipping to a positive charge as the sodium channels open. Then the membrane is going to completely what we call depolarize, switch its charge from negative to positive, right? When it depolarizes, calcium channels open, right? As the calcium channels open up, then that's going to cause the sinoatrial node to reach threshold, and that causes the action potential, which means that we're going to cause it to be able to be passed down throughout the cell. So this is how we're able to have a concert. Basically, all of the cells are responding to this SA node at the same time, meaning that we're going to get an action potential excited in all of the cells simultaneously, which is important because we want the contraction to occur in all of these cells, not just in half of them. So the sinoatrial node, which is found in the right atria, is going to be responsible for the contraction of both the left and the right atria. Okay, so this is the atrial excitation. This is that little cue, right? So we're going to get an excitation here in the atria, which is going to transfer over to the left atria as well. This is the lub event, the contractile event that pushes all of the blood into the ventricles from the atria. That happens at the same time, both on the left and the right. Then we end up with atrial relaxation. So we end up with refilling of the atria that's going to be pulling in from, like I said, the coronary sinus and the vena cava, and on this side coming in from the pulmonary pulmonary arteries. No, pulmonary veins. Pulmonary arteries go out, pulmonary veins come in. So returning from the pulmonary veins into the left atria. Again, that's going to happen at the same time. And then when we have the ventricular contraction, which happens right after the ventricular excitation, then we're going to, excitation causes contraction, then we're going to force all of this blood out through the semilunar valves. These are going to go out to the lungs. These here are going to go out through the aorta to the rest of the body. And then we end up with ventricular relaxation, and we just lather, rinse, repeat. Atrial excitement, atrial relaxation, ventricular excitement, ventricular relaxation, atrial excitement, atrial relaxation, ventricular excitation, ventricular relaxation. So this is the electrical conduction that's happening through, here's the SA node. The atrioventricular node is not depicted, but basically it's really clear to see that the SA node is going to send that signal to all of these cells, and then the AV node is going to send that signal to all of these cells, causing that contractile event. Okay, so heart rhythm is really important. That lub-dub is super important. And if we end up with an abnormal lub-dub, lub-lub-dub, or lub-dub-dub, or something like that, or like something in between, that can be a disruption of the sinoatrial node. And it can be caused by multiple different things, including coronary artery disease, hypertension. This is a heart attack or a myocardial infarction, not to be confused with a myocardial infection, which would be a heart infection. A myocardial infarction is when we are going to have either a full contractile event with all four at once, causing no circulation, or a lack of a contractile event, also causing no circulation. Hyperthyroidism can cause this because remember the thyroid is involved in your metabolic pathways, so an increase in or overactive thyroid can cause defects in your metabolic pathways. We can also have defective heart valves that's going to be a defect that you're born with. Or it could be that you're susceptible to different types of stresses, or you're under the influence of different types of drugs or chemicals that are affecting the ability of the SA node to function properly. Okay, I know I promised you there wouldn't be a lot of math, but this is going to be a little math. So cardiac output is going to be equivalent to, basically cardiac output is how much blood is being put out by the heart every minute. And so the heart rate is going to be beats per minute, and the stroke volume is going to be volume per beat, which is going to give us the volume per minute in the cardiac output. Now, heart rate is influenced by a bunch of different factors. Remember, the sympathetic system is going to be involved in increasing your heart rate. Your parasympathetic nervous system is going to decrease your heart rate. And then we have different drugs for each of these pathways that the heart is responsive to, whether we're going to cause an increase or decrease in our heart rate. Now, stroke volume is going to be the equivalent of how much volume we started with versus how much volume we ended with, okay? So again, systolic is contractile, diastolic is relaxation. So the end diastolic volume is how much is there when we are completely relaxed. Then we have a contractile event, and then we say how much is left over. So stroke volume is the end diastolic volume, how much is there to begin with, minus this end systolic volume, how much is there after contraction. And then we'll just multiply that by your heart rate to figure out your cardiac output. Okay, as I mentioned, there's a ton of factors that affect cardiac output. It's a multifactorial system. But they come down to one of two things, the heart rate or the stroke volume, right? So if you want to increase your cardiac output, you're going to have to either increase your heart rate or increase your stroke volume, okay? So heart rate can be influenced by multiple things: body temperature, the hormonal concentration of your thyroid hormones, concentrations of your impulses that are parasympathetic versus the amount of them that are sympathetic. All of that's going to be involved in your heart rate. Okay, your stroke volume is only two things: pressure before, our volume before and volume after, right? So the preload is how much volume is put in, and the afterload is how much is there after we've had the contractile event. So the preload can be determined by venous return versus the distension of the ventricles. How much blood comes in, as well as how much blood can we accommodate inside the ventricles. How distendable are they? And distensibility is going to be related to your cardiovascular fitness, which you can increase by diet and exercise, etc. And the venous return is going to be related to three things: the amount of blood volume that you have, the respiratory pump, which is how much blood is coming back in from your respiration, right? So from breathing, as well as the muscular pump, which is what's returning things into the vena cava. And that's all going to be involved in, again, that venous return. Okay, so if we look at blood volume, that's related to the concentration of water as well as ions and our function of our kidneys. And the respiratory pump is going to be how hard are our lungs working, which can be increased if we exercise. Okay, so again, all of these are going to come down to heart rate, which can be affected by these, stroke volume, which is just affected by the concentration before contraction, concentration after, well, volume before contraction, volume after contraction. And all of this leads to, again, what we call cardiac output, which is the heart rate times the stroke volume. And the cardiac output is directly related to the blood pressure as well as the blood volume, right? So these are all the different factors that affect cardiac output. And a fair game question would be to say, if we increased in exercise, how does that affect XYZ? So you'd have to demonstrate that an increase in exercise would increase the respiratory pump, which would increase the venous return, which would increase the preload, and probably increase the stroke volume, leading to an increase in cardiac output, right? Increase in exercise would probably also increase the sympathetic impulses, which would increase your heart rate, which would also lead to the increased cardiac output. Okay, so again, the preload is going to be how much we have stretching, basically, So it's going to be proportional to the amount of the myocardial stretching just before the contractile event. So how stretchy is the balloon? Afterload is the pressure that's left over that we have to overcome to force open the aortic and the pulmonary valves. So these guys have a particular pressure. They're going to stay static until you overcome that pressure, and then they're going to open up. Now, afterload is affected by anything that is going to increase your systemic or your pulmonary arterial pressure. Good examples of this would be something like hypertension, okay? And the preload and afterload are going to directly be related to the cardiac output. So if you increase your preload, you could increase your cardiac output. Or if you decrease the afterload, you can decrease your cardiac output, right? Sorry, increased afterload means there's some left over. So if you increase the afterload, that means that if you have more residual volume afterwards, that means you're going to have less that was expelled. And they're going to look at this specifically when they're talking about the different stages of heart failure to see how much is left, right? How much afterload do you have versus someone who is a normal, healthy heart. As I mentioned, venous return is going to happen because of seepage. So we're going to be pulling things in via suction. We also are going to use a skeletal pump. This is why they tell you to stand up and walk around the airplane every couple of hours to stretch your legs, because they want to make sure you don't get something called deep vein thrombosis. So these are your deep veins. They have one-way valves. And when you walk around, you're basically using your muscles to push the blood in and up and in and up and in and up, one little pump at a time. If you sit still for a while, however, that blood can pool in your lower limbs in these deep veins and cause what's called a thrombosis. Now, a thrombosis is basically a clot that can then get dislodged. So if you throw that clot, it can end up in bad places. If it ends up in your heart, it can cause a heart attack. If it ends up in your coronary arteries, for example. If it ends up in your brain, it can cause a stroke. So we don't want to have a DVT or a deep vein thrombosis. We don't want to get them. We definitely don't want to have one dislodged. So if we do have them present, what we're going to do, we're going to hopefully see a doctor and have them flushed out so that we can prevent having one dislodge and cause a stroke or a heart attack. Okay, so that's the skeletal pump. The respiratory pump works when the blood is being pressurized back into the heart as we are inhaling and exhaling with the pressure of the thoracic cavity. So every inhale and exhale is going to change the pressure of the thoracic cavity, meaning the blood's more likely or less likely to be drawn into the heart via the veins and the vasculature. So every breath actually helps return the blood supply back to the heart as well. All right, so we haven't really talked about lymphatic tissues just yet. Lymphatic tissues are going to allow us to bring back any fluid that is lost by the blood supply that is not returned by the blood supply. So almost all of the blood supply that is going to be lost by the capillaries. So here we have the arterioles, we have the arteries, the arterioles, and we're going to have fluid loss across the capillary bed, and then we're going to have fluid returned back into the venules by slow drainage, back into the veins, back into the heart. But not everything returns this way. Some things are going to get kind of caught around the outside of the cells, and if we don't have the fluid return, we're going to end up with edema or swelling. So how do we prevent that? Well, we pick that fluid back up into the lymphatic tissues. Okay, so the lymphatic tissues are going to return any of that extra blood or fluid back into the blood supply. But first, it's going to filter it through the lymph nodes, which are going to help eliminate any of the microbes that might be sitting in there. Okay, so basically, we're going to start off with the arteries. The largest artery is going to be coming from the heart. That's the aorta, largest elastic artery in the body. Then we're going to branch off into arterioles, branch those into capillaries. And then those capillaries are going to be the site of fluid loss, which is going to feed all of the cells in the body by exchanging with the interstitial fluid, which then exchanges with the cytoplasmic fluid. And then we're going to be returning the fluid back in via the venules and the veins. And as the fluid returns, it's going to have lost its oxygen, therefore it's depicted here as blue, and it's going to have picked up metabolic wastes and carbon dioxide that we're going to want to off-gas or filter through the liver, depending on where it's going to go, liver and kidneys for like the metabolic waste. Okay, so this shows you where the blood volume is in most of your body. Almost all of it is in your veins and venules. These are called your blood reservoirs. Although the vasculature is approximately the same for the veins and the arteries, remember it's not under pressure, so it's going to spend a lot longer in that area, which means that we're going to basically be going through this whole thing like a carnival ride, and then this is going to be the nice walk back to the car, nice slow walk, right? Then we're going to, again, once we return, get pressurized, get oxygenated, and then lather, rinse, repeat. Okay, what's the difference between the arteries and the veins? Several major differences. One, arteries are under pressure. Veins are not under pressure. So that means that the muscle of the vein is much smaller than the muscle of the artery. See how thick the muscle of the artery is here? Additionally, this is a lot more elastic. So the arteries are going to be under arterial pressure, which means that every time that the heart pumps, they're going to be subjected to a new volume, which means they're going to have to stretch and contract and stretch and contract. So they are elastic vessels. So they have a nice layer of an elastic membrane with an internal and an external elastic membrane. Now this one also has that internal and it really only has the internal elastic membrane, but it's not going to be as thick and the muscles aren't going to be as thick. Some other interesting things about the veins that do not appear in the arteries are these one-way valves. So again, the blood's going to get pushed by the skeletal muscle squeezing up, and then when it comes back down, it's not going to be allowed to return. So it's just going to continue to move upward in these small, short pumps. Okay, these are all controlled by the autonomic nervous system. So vasodilation and vasoconstriction are controlled entirely by the sympathetic and parasympathetic divisions of the autonomic nervous system. Okay, so again, the arteries are going to be where the blood flows out, and the veins are going to be returning the blood to the heart. Again, the walls of the veins are thinner, they don't have to be under pressure, and we have these special one-way or unidirectional valves that prevent the blood from flowing backwards or pooling. Okay, so these specialty one-way valves actually can sometimes lead to a very pesky condition that women will get very upset about called varicose veins. So varicose veins are veins that have become twisted because they have incompetent valves or leaky valves, and so the blood's going to just go back in. So instead of just going up and then stopping at the valve, then going up and stopping at the next valve, it's going to leak backwards. And so when we have backflow of blood, we can end up with the veins or vasculature being shown throughout our limbs. Approximately 15% of adults suffer from this condition, some of it more extreme than others, and it typically is going to happen in the lower limbs, like in the legs. Again, for the same reason that we talked about having those deep vein thrombosis, because the blood's going to pool in those lower limbs, and then it's only being pushed back up by the skeletal muscle pump mechanism. But if the skeletal muscle pump mechanism is relying on these one-way valves and they're not working properly, the blood's just going to come right back down into the veins. All right, so this is an anatomy of the difference between the arterioles and the venules. So arterioles, which are feeding into the capillary bed. Remember, venules are returning from the capillary bed. Arterioles are going to have specialty smooth muscle cells around them that are able to constrict or contract if we need to change the blood. Well, we'd be changing the diameter, which would then be changing the blood pressure by constriction or relaxation. But my point here of this says that we're going to have these specialty endothelial cells that line the arterioles and the venules, as well as a basement membrane that surrounds the whole thing, as well as a layer of smooth muscle tissue here in the arterioles, and as well as connective tissue layers. Okay, so the venules and the arterioles connect the capillaries. Capillaries are going to be the actual leaky area where we have the site of gas exchange and nutrient exchange. Capillaries are going to be very small. Again, they're going to be so small that only one blood cell can go through at a time. They're composed almost entirely of endothelial cells, so the membrane's almost entirely gone now. And almost every cell in the body is going to be right next to, if not 2 cell layers away from a capillary bed. So almost all cells of the body are within 100 micrometers of a capillary. Now, in the capillaries, we're going to have a much lower blood pressure than we saw in the arteries. Why? We're leaking out, so there basically just became a screen door on our hose, so the fluid is just going to be lost to the external environment. Now, we can close off the different capillary regions with precapillary sphincters based on which tissues need the blood the most. So if we are over-exercising, we might be sending that to certain muscles and cutting off the digestive tract. If we're in rest and digest, we might be upregulating the blood volume to the digestive tract and cutting off the blood volume to other areas. So we can use these precapillary sphincters to decide who needs the blood the most, essentially, based on the physiological needs of the tissues. As I mentioned, this whole thing works because these capillaries are super leaky. About 4 liters of fluid is going to be lost out of our circulatory system into our capillary bed every single day. And then we use a section called the lymphatic system. The lymphatic system, as I mentioned, is going to pick up any of the excess fluid that is not going to be picked back up by venous return, and it's going to be filtered out through lymph nodes. Now, remember that exchange is going to be from the capillaries into the interstitial fluid, from the interstitial fluid into the lymphatic fluid. The original exchange is actually from the blood into the interstitial fluid, from the interstitial fluid into the cells, and then back out again. But if we end up with an accumulation of this interstitial fluid, it can then be picked up by the lymphatic vessels where it's going to be called lymph. Now, ultimately, the objective is to restore the fluid back to the bloodstream. But before we do that, we're going to filter through these lymph nodes, which are going to have special T cells and B cells found within them that are able to engulf and ingest and destroy any foreign microbes that might be invading our body. So it's going to basically filter out the bad things and then return the liquid back to the blood supply cleaned. Okay, so as you might imagine, the lymphatic vessels are going to overlap pretty much anywhere you see a capillary bed. So the cardiovascular system and the lymphatic system are going to look fairly similar, but the purpose of the lymphatic system is twofold. One, return the volume of the fluid back into the cardiovascular system, and two, filter it first to make sure that it doesn't have any bad guys or foreign invaders in it. So what happens when we have fluid exchange from the arterioles through the capillary bed, we have fluid loss and we have fluid return, but we don't necessarily return as much fluid as we have lost, and so anything extra is going to get picked up by these lymph capillaries. Now, lymphatic capillaries have these one-way like valves inside, so you can leak in, and then you're going to be pushed through these one-way valves again until we reach regions known as lymph nodes. All right, so as I said, the lymphatic system is going to almost directly overlay with the cardiovascular system. So anywhere that you're going to see a lot of vasculature, right? Like you've got your carotid and your jugular here, you're also going to have cervical lymph nodes. You've got your brachial and axillary arteries here, you also have lymph nodes here. You've got your abdominal aorta, well, you've got lymph nodes on either side of it that are also serving to capture stuff. So the drainage path with the lymphatic system is going to overlay with the cardiovascular system, but basically the point is that we're going to drain back into the cardiovascular system at these left and right subclavian veins, which are known as the lymphatic ducts. Okay. So we are able to move fluid through the lymphatic vessels through the process of peristalsis, which is just a constant smooth muscle contraction that's going to be progressively moving things forward. So slow contractions that are going to move the fluid towards the lymph nodes and then back towards the subclavian. And we also have one-way valves that we also saw in the venous return. This is going to help us prevent flowing of lymph backwards, as well as a similar skeletal pump mechanism that we saw in venous return. Now, the lymphatic vessels is going to have a nice slow, low pressure flow. It's not under high pressure flow like we see in the arteries. And its purpose is to take a detour into the lymph nodes. The lymph nodes are kind of like a Genki sushi for all of these B cells and T cells who just want to eat up all the foreign invaders. So they just basically sit put while there's a flow of food coming across them, and each of them eat what they like. So there's a specific invader, like a microbe, that's going to get eaten by a particular type of immune cell. But a virus will get eaten by a different type of immune cell, and a parasite will be eaten by a different type of immune cell. So inside this Genki sushi, we have multiple different diners who have different appetites who will be eating basically everything that should not be there in the first place, all of the microbes. All right, so this here is going to show an overview of the circulatory routes, basically the routes that blood takes through the body. So I've already basically shown you the cardiopulmonary route coming in through the right atria from the coronary sinus and the vena cava, superior and inferior vena cava, into the right atria through the right atrioventricular valve, into the right ventricle, back out through the right semilunar valves, which takes us to the pulmonary arteries, which will take us to the left and right lungs. Then we're going to come back in through the pulmonary veins. Again, this is the only time that you're going to see venous return shown as oxygenated and arterial flow shown as deoxygenated. All right, coming in through those pulmonary veins into the left atria, through the left atria to the left atrioventricular valve, into the ventricle, and then out. This arrow is pointing the wrong way. This arrow should be here. Okay, we're coming into the left atria, out through the left ventricle. And then that's going to go into the aorta, where we're going to branch off into three major branches. One of those branches is going to be the one that's going to take you up into the head. So this capillary network is going to be the head and the forelimbs that are going to be going to come off of the branch of the aorta. Then we're going to have the aorta go down the abdomen, where it's going to hit all of the abdominal organs. So celiac trunk is going to be for the stomach, for example. Hepatic artery is for the liver. Splenic artery for the spleen. Gastric artery for the stomach, right? So you can see what I'm saying. These are all going to be regions that are going to be feeding into the abdominal cavity to feed the organs. And then we have capillary beds depicted here, which you can see here is like a turning from red into blue is going to be that nice purple. Capillary beds are going to be the site of gas exchange. Then we're going to get venous return leading back into the heart itself. Okay, so again, this is going to be cardio circulation, pulmonary circulation, and this and that are systemic circulation. Okay, so this is showing the pulmonary circulation. Again, we're going to be coming in from the pulmonary artery, left and right pulmonary artery, ending into the alveoli of the lung, where we're going to actually have the site of gas exchange. We're going to off-gas our carbon dioxide. We're going to pick up our oxygen. Then we're going to come out through the pulmonary, come back in through the pulmonary veins, into the left atrium, and then from the left atria through the left ventricle, back out through the aorta. Okay, so this here talks about the different circulatory routes of the blood supply. So this is just going to be kind of an overview of the major, call it a map, I guess, of the vasculature. So coming off of the aorta, which is the largest elastic artery of the heart, we have the ascending aorta. The arch of the aorta splits into three regions: brachiocephalic, left subclavian, and common carotid. The common carotid is going to feed the face and head. The left subclavian is going to feed the left arm. The brachiocephalic is going to branch and feed the right common carotid and the right arm. As we head down the arms, we're going to end up reaching so here we have the brachial. So we have the axillary, which is this part here in the shoulder. Then we have the brachial. And then as we head down, we're going to have the ulnar and the radial. And it's not showing here. We also are going to then feed down the palmar arches, which is going to feed into the hands. And then if we follow this aorta down into the abdominal cavity, the abdominal aorta is going to branch off into the celiac trunk, the hepatic trunk, the renal trunk. So basically we're feeding the stomach, we're feeding the liver, and we're feeding the kidneys. As we follow our way down, we're going to end up also feeding the gonadal. So we have the left and right gonadal, we have the mesenteric. They're going to feed all of the internal organs, including the reproductive organs. Then we're going to split here. Here's the iliac. So the iliac is going to split into the left and right iliac. That's the common iliac. The common iliac is going to split into the left and right, so the deep and superficial of the left and right iliacs. Following this down, the iliac is then going to become the left femoral. The femoral also splits into the deep femoral and the superficial femoral. Then we reach the popliteal, that's the knee. And then we're going to feed into the left anterior tibial as well as the posterior tibial. So these are going to be split to feed the tibia side, whether we're going to the back or the front. Then we have the fibular as well, which is also known as the perineal. And then it'll all feed into the dorsal. The dorsal pedalis is going to be one quick and dirty way to determine the blood pulse of an individual. And then we're also going to have that split into the dorsal metatarsal and the dorsal digital, which feeds the feet. Okay, so this is showing the abdominal aorta and the different circulatory routes that's going to take. So here's the celiac trunk, the hepatic trunk, the splenic trunk, the gastric trunk, and then we also have the superior mesenteric, inferior mesenteric. This is all called the mesentery. Those are what we're going to feed into. So mesenteric is going to feed the intestines. All right, so now we're getting into the circulation inside the brain. I'm not going to linger too much here. I don't expect you to memorize most of this, but I do want you to understand that circulation in the brain is super important, and a lack of circulation in the brain can lead us to a stroke very quickly. The brain's going to be utilizing a lot of oxygen, and it's going to be needing a ton of blood supply. So here we get the blood supply again coming in through the common carotid. I'm going to take a moment to emphasize here that people always think that you slice the jugular when you see that blood that slurs. The jugular is a vein. It's venous return. It's going to be a nice slow seepage. What you're seeing when you see that spurt, that arterial flow, that arterial spurt, that would be coming from a common carotid. So if you see someone with their head cut off in a movie and you see the spurting, you're not going to say, oh, they got the jugular. You're going to say, oh, they got the carotid artery. But it is a really common misconception. All right, here is the right maxillary. So we're going to split up as we go up the carotid. We're going to split into the jawbone. So we have the maxilla that's going to be fed, and then we also are going to have the internal and the external sets that are going to feed the brain. So what does that look like here? Okay, so here's the arteries that are going to feed into the brain. And again, this is just for your reference. I'm not going to quiz you on this, but they're going to be named based on the areas that they serve. So this is going to serve the inferior cerebellar region, posterior inferior, and anterior inferior cerebella. This is going to be feeding to the cerebral region. So here's the posterior cerebral. We also have the anterior cerebral. We just did the inferior cerebellar. Here we have the superior cerebella. So basically the names are going to be directly correlated to the regions of the brain that they surface. And that's really all I need you to take home from this slide. All right, let's talk about the circulatory routes of the limbs. So coming off of the aorta, we're going to have here the brachiocephalic, which splits into the common carotid and into the brachial. The brachial, first we're going to go through the axillary, and then we'll hit the brachial. Then that's going to split here at the elbow into the radius and the ulnar, which are then going to feed the palmar and the digital. As we head down from the abdominal aorta, we're going to split into the common iliacs, the left and the right common. those left iliac and right iliac common are going to split into the internal and the external, right and left iliacs. And then we're going to feed down into the femoral. The femoral is going to have a superficial and a deep. So here's a superficial. The deep's going to run internal. And that's going to lead into the popliteal. The popliteal then leads down into the popliteal is the knee region that leads down into the tibia. We have the anterior and the posterior tibial region, as well as the fibular region, and then that leads down into the dorsal pedalis, which then into the digits of the feet, right? So the digital. Okay, so that is all arterial flow. Now let's talk about venous return. So if I just talked about everything going off of the heart, now I'm going to talk about everything returning from the heart. So I'm going to start at the digits and work our way up. So the most distal region obviously is going to be the dorsal digital. We're going to work that up to the venous arches. Now you'll see we have a lot more routes of blood flow back than we did blood flow out, and that's because a lot of these are going to be like little return series of areas. So we're going to have because we're having a slow seepage of return, we might have to have more regions of return. But anyway, we're going to go up to the anterior tibial, posterior tibial, then we'll have the popliteal. Then we're going to end up with something called the saphenous. So we have the small saphenous and the great saphenous. These are going to run up the leg along with the femoral. So these we haven't seen before. We didn't have a saphenous when we were talking about arterial flow. Anyway, so as we head up, then we're going to get into the femoral, as I mentioned, then the iliacs, internal and external iliacs, the common iliacs, and then we're going to end up into the mesentery, superior, inferior mesentery, all of the abdominal organs, including the hepatic region, the splenic region, the gastric region, etc., all headed back up the inferior vena cava and dumping into the right atria. If we're looking at the arms, we're going to start with the palmar digital, work our way up to the venous plexus. Then we have this antebrachial region, which is going to be the area that's going to be containing the ulnar and the radial return. Then we have the basilic, the brachial, the axillary, and that's going to also be the cephalic here, which is also going to be draining into the right coronary, into the right ventricle, right? Sorry, I apologize. The superior and inferior vena cava, as well as the coronary sinus, all drain into the right atria. I just said right ventricle, but I meant right atria. So we're going to drain into the right atria, and then go into the right ventricle, then out to the lungs, then back into the left atria, left ventricle, back out for systemic circulation. Okay. So this is basically showing you how the blood is going to return back into the heart. Again, it's going to happen from the superior and the inferior vena cava as well as the coronary sinus. This is the same drainage routes of the brain that we just saw for arterial flow. We're going to see venous return. And again, we're going to see a lot of these regions depicted based on where they feed. So they feed the cerebral region. They have the middle, superior, and inferior cerebral veins, for example, inferior cerebellar veins, for example. But we're also going to see some regions that are sinus regions. Sinus just means an area that's going to have pooling. So we're going to have a lot of regions where the blood's going to pool to then be returned kind of all at once. And in this way, we can have blood coming from multiple regions and having basically intersections within the brain vasculature. Again, this isn't something I'm going to quiz you on. I just kind of want you to understand some of the routes of the blood flow. All right, so the veins of the upper limb. Again, if we're starting with the wrist region, we're going to come up the median antebrachial into the ulnar. Here's the radial. This one is the cephalic. Cephalic means head, but it's actually going to be headed up towards it's going to branch into the brachiocephalic. So here's the brachial, and then that's the cephalic. Here's the basilic, comes up in here. We also have the axillary, which is where the basilic and the brachial are going to branch off. That's going to lead into the subclavian, which then is going to lead into the superior vena cava. Coming up from the lower limbs, here we've got the great saphenous. Again, this is a return vessel that we do not see in arterial flow. So we have the small saphenous, which I don't, so yeah, here's the small saphenous, and the great saphenous. The great saphenous runs all the way from the foot up to the hip. Small saphenous is going to run from the foot up to the knee. Okay, here's the popliteal. Popliteal, again, is knee region. And we're going to head back up until we hit the femoral. The femoral is going to join with the great saphenous to become the iliacs. Here we have the internal and the external iliacs combining to become the common iliacs, which then lead into the inferior vena cava. And again, we'll dump into the right atria. Okay. Now, when blood comes off of the heart, it's under high pressure, and it almost immediately is going to lose some pressure as it travels out.